Dear colleagues, it's a great pleasure for me to introduce the Advances Type 2 Inflammatory Diseases, which focuses today on nasal polyps, a type 2 inflammatory disease. We will look at efficacy and effectiveness of biologics in treating those patients difficult to treat or refractory patients to standard treatment. This is the disclaimer. And here are the prescribing information, and you will find further material in the internet. The agenda today is about type 2 inflammatory airway disease. What are the mechanisms? How does type 2 work? And what are the consequences in clinic of those type 2 cytokines? This I will do myself, and I'm from Belgium. The second talk will be Claire Hopkins from the United Kingdom, and she will look into biologics and do they make the cut in patients with chronic rhinosinusitis with nasal polyps. We will review the latest evidence supporting the use of biologics in patients with a history of prior surgery and/or eosinophilic statuses. And finally, the real-world applications of biologics in patients with chronic rhinosinusitis with nasal polyps will be discussed by Witske Fokkens from the Netherlands, before we go to a panel discussion and questions and answer session. Our learning objectives today are really understanding type 2 inflammatory disease, understanding the role of these cytokines in interleukin 4, 13, and 5 in the pathophysiology of chronic rhinosinusitis, and of course, discuss the role of biologics then in patients with or without previous nasal surgery and patients stratified by level of blood eosinophils. We will look finally at the latest data on the real-world effectiveness of biologics in patients with chronic rhinosinusitis. Real-world data after you have seen these phase 3 clinical trials, which all convinced us to go on with these biologics. I will focus on chronic rhinosinusitis with nasal polyps as a type 2 inflammatory airway disease. My name is Claus Bachert from Belgium, Ghent University. Here are my disclosures and my presentation objectives. Establish chronic rhinosinusitis as a type 2 inflammatory airway disease. What does that mean? It's not clear to everybody. Type 2 is a relatively new inflammatory type that we have to learn of. Highlight the role of type 2 cytokines, interleukin 4, interleukin 13, and interleukin 5, in the pathophysiology of chronic rhinosinusitis, and review the identification criteria from the latest chronic rhinosinusitis management guidelines. The clinical features of this disease is very well known to us. We know the typical CT scan. We understand that nasal obstruction and loss of smell are the most important symptom to the patients, followed by nasal discharge and facial pain in less of the patients. But what we have to think of also is the pathophysiological features, such as the infiltration of immune cells caused by a barrier dysfunction, leading to tissue remodeling, mucus overproduction, mucociliary dysfunction, and microbiome alterations. So it's a very complex picture we have in terms of pathophysiological features, which is present in more than 80% of patients with chronic rhinosinusitis with nasal polyps, and certainly clearly present in the more severe patients and those with asthma comorbidity. Our understanding of the role of type 2 inflammation goes a long way back. First, it was focusing on interleukin-5 in the 90s of last century. Interleukin-5 synthesis was shown to be upregulated in nasal polyps in 1997 by our. And we understood that with the elevation of interleukin-5, also other parameters, IgE, eotaxin, leukotrienes, are increased in the nasal polyp. It took till 2008 till the Th2 inflammation was coined. And there was evidence of not just the T helper cells, but also the innate lymphocyte cells to be part of this type 2 inflammatory process, which is then established in EPOS guidelines, in ICAR guidelines, and American guidelines, to be the most frequent type of inflammation in chronic rhinosinusitis with nasal polyps. And this is continued in the newest guidelines in 2019, 2021, Euphoria, in EPOS, as well as the American guidelines, ICAR, again. It is very clear that these cytokines in these guidelines also are referred to type 2 inflammation specific in more than 85% of the patients. And here you see the most important latest guidelines mentioned. All of these guidelines mention interleukin-4, 5, and 13, the type 2 cytokines, and mention how they translate into actually symptoms, disease, but also comorbid disease and severity of disease leading to recurrence of disease after surgery. And of course, we have different expressions for what we see here from asthma comorbidity to aspirin sensitivity and sometimes even idiopathic bronchiectasis, which also are related to type 2 inflammatory disease. When we look at the type 2 inflammation gene signature, it gets very clear that we obviously have to do with a very complex inflammatory type. We do see a lot of different abbreviations here, which represent certain genes. And specifically, IL-4 and IL-13 responsive genes are broadly dysregulated in polyp basal progenitor cells. And type 2 inflammatory genes can be found clearly upregulated there, or as it is in asthma, in those nasal polyps. And we will look more into what specifically they do in the next minutes. And here's a survey, actually really setting interleukin-4, 5, and 13 in the center of this immune reaction. Let us start with the epithelium, which of course is exposed to the environment, to the allergens that might fly around, but also to bacteria, microbiome, viruses, and even biofilms or bacterial organizations, which of course stimulate the epithelium to release certain cytokines such as interleukin 25, 33, and TSLP. And these specific cytokines on the left side of this slide have the function to activate innate lymphocyte 2 cells, which in response then produce IL-5 and IL-13. Interleukin-5 has a major role in the eosinophil trafficking from the bone marrow and activation in the bone marrow until the tissue. So eosinophils are armed with an interleukin-5 receptor, which comes in different forms. And this regulation, these different forms of the IL-5 receptor actually allow the regulation of eosinophil trafficking and activation. And we will see later how also interleukin 4 and 13 are important in the regulation of eosinophil trafficking. On the other hand, we have the B cells on the lower panel here, which is to be developed into plasma cells. And that is done via certain processes driven especially by interleukin 4 and 13, including B cell class switching, which then leads to IgE production. Of course, these B cells do form other immunoglobulins also, but they make a lot of IgE, which is very typical for nasal polyp disease. IgE then arms mast cells and basophils, and upon contact with stimuli, again, releases cytokines, including IL-4, 5, and 13. On the other hand, IL-4 and 13 also have an effect on the barrier dysfunction, mucociliary clearance, goblet cell numbers. And you see how it started in the epithelium and it fires back to the epithelium to actually change the integrity of the epithelial barrier, to change the tightness of tight junctions, the number of goblet cells, and of course, mucus secretion of the epithelium, which favorizes again the activity of bacterial or viral germs in the inflammatory disease, which triggered the whole thing in the beginning. And you see also that other cells like macrophages are part of this disease. M2 macrophage polarization makes it impossible for macrophages to cleverly defend the inflammatory mucosa. And we have finally fibrin cross-linking with the edema, which actually is a hallmark of tissue remodeling and polyp formation. Once more here on the eosinophils, of course, we know that interleukin 5 is an important part for activation of eosinophils in the bone marrow and mobilization to the blood. But interleukin 4 and 13 also play a pivotal role in the upregulation of chemotaxis of eosinophils, directing them into the nasal mucosa. And finally, interleukin 5 again takes over for eosinophil survival and local activation of the eosinophil. At the same time, IL-4 and IL-13 are really key in understanding B cell class switching, which then leads to IgE production in chronic rhinosinusitis, which has nothing to do with allergy, by the way. This IgE is polyclonal and has a high titer and high concentration in the nasal tissue. You see that the generation of IgE, of course, leads to the arming of mast cells and basophils, binding to the high affinity IgE receptor. And these cells, again, upon degranulation, would activate and would contribute with pro-inflammatory cytokines, but also interleukin 4 and 13. And we see a second example where the generation of this inflammatory pattern keeps turning and keeps chronic in the sense of a really chronic inflammatory disease that maintains itself. So we understand how we come from environmental and host factors to the epithelial barrier dysfunction, which then talks to the immune cells, type 2 cytokines, and then type 2 inflammation as a consequence. And this persistent inflammation fires back to the epithelium to lead to mucociliary dysfunction and an imbalance of the microbiomes. Very often Staphylococcus can be found, and we talk about that later. And at the same time, to the remodeling of the sinonasal mucosa and nasal polyp formation. So we also understand that barrier dysfunction and type 2 inflammation are tightly linked to each other. Goblet cell hyperplasia, mucus overproduction, and mucociliary dysfunctions are the main themes of this epithelial dysfunction. And you can see here very nicely that IL-4, 13, and to a lower extent also interleukin-5 is part of that driving mechanism for such changes on the epithelium. And we also can see that the epithelial junctional integrity is very much dependent on cytokines such as IL-4 and IL-13, and specifically also in the combination, these cytokines downregulate the expression of tight junction molecules, E-caterin expression, for example, which of course leads to an impairment of the epithelial barrier. So we understand that barrier dysfunction and immune responses are linked, in the barrier dysfunction making the immune response possible, but the immune response further firing back to the epithelium and increasing the barrier dysfunction, which of course in the circumstances of an environmental effect on the epithelium leads to further chronicity of this disease. And we see that once this disease has been established, viruses, bacteria, and other pathogens have it even easier to pass through the epithelium, to modulate and activate the epithelium, to release further cytokines and fire down to the immune cells to actually maintain a pathologic disease state such as a type 2 immune reaction. And Staphylococcus aureus, as we know very well from the nose, it's very often found in the nose, and it's with its super antigens actually contributing to this inflammation in the case of an epithelial barrier and an immune dysfunction in the mucosa in many ways. And what you see here is a list of certain molecules that have been shown to be upregulated by Staphylococcus aureus or its products, such as the superantigens in plasma cells, in T cells, in dendritic cells, mast cells, and macrophages. So we understand that bacteria such as Staphylococcus aureus, more than others, really contribute to this chronic inflammatory disease to a large extent. But this is based on the epithelial disruption and the pathologic immune reaction. Staphylococcus aureus otherwise can reside in the nose without further disease. So we understand that immune reactions such as type 2 are linked to infections, specifically respiratory infections. And of course, what we could show in the Sinus 52 trial was actually that part of that effect can be counteracted by dupilumab. And what you see here is the annualized rate of specific treatment emergent infections. And if you look lower down here, it's upper respiratory infection and upper respiratory infections as an abbreviation, which all was possible to actually monitor through this Sinus 52 trial. And we see very clearly that there is a disturbance. However, with dupilumab, the number of infections really decreases, and the risk ratio tells you that about 40% of these infections can be actually avoided in these patients when adequately treated with dupilumab. So to summarize, it is very clear that chronic rhinosinusitis is a chronic disease accompanying the patients for decades. It is a disease of the upper airway clearly impacting type 2 inflammation. Type 2 inflammation is present in at least 80%, and the more severe the type 2 inflammation, the higher this percentage will be. Type 2 cytokines play a role, and we have heard about interleukin 4 and 13 in terms of eosinophil trafficking, B-cell class switching, epithelial barrier dysfunction, and goblet cell hyperplasia and mucociliary dysfunction. And interleukin 5 with a specific role in eosinophil maturation and activation, which then again needs the IL-4 and IL-13 cytokines to actually migrate into the mucosa. So we understand that patients with type 2 inflammation not only suffer from this inflammation, but have an increased risk for colonization, for infection, and this, of course, is part of the disease. We know that very well from our patients, and it should be considered in their management approach.